Hello, I'm Dr. David Levien, President and CEO of the American College of Healthcare Trustees. We're thrilled to have some true experts today in the field of BACRA and MIPS and other aspects. Many of the physicians in our network have told me that they have a hard time keeping up with many of the advances in payment schemes. And I've read some scholarly material that suggests that doctors across the country find this administrative burden very difficult, even a source of dissatisfaction and burnout and people leaving the profession. So I'm thrilled to have two esteemed guests that are so knowledgeable in this space and are helping physicians and doctors' practices and hospitals remain sustainable. We have Dr. Baran Erdik, who's both a physician and an expert in public policy. And we have Stan, we're very proud of, and that's helping physicians in hospitals and clinics. So, Baran, would you please take it away?
Thank you. I am Dr. Baran Erdik. I'm a physician as well as I have been dealing with regulations for a while now. So after practicing in several countries, I received a master's degree in healthcare administration and policy, and I've been focusing on healthcare delivery in the US, particularly with regards to any sort of CMS regulations, as well as those of accrediting organizations such as the JCO or DNV. I have been working for a state survey agency, and I have handled over 2,500 allegations of non-compliance, as well as various self-reports. So from a regulatory and legislative perspective, I am extremely in tune with what the CMS is pushing, what the changes are, and what the kickback from the physicians is. And with that, I give it to Mr. Gutkin.
Thank you, Dr. Erdik. Thank you, Dr. Levien. So pleasure to be here. Thank you for the ability to contribute. My name is Stan Gutkin. I'm COO of CCM Health. Our focus is reduction of healthcare costs, reduction of hospitalizations, reductions of readmissions. We developed a technology that's utilizing artificial intelligence and machine learning to deliver just that. And in today's session, we're going to cover some of that aspects. Thank you.
That's great. Dr. Erdik, some of our followers don't actually know what BACRA and MIPS stand for. They have a practice manager or an administrator who takes care of that aspect. And some of those practice managers and administrators really are not facile with some of the regulations. And I know that some of the incentives are going away, but some of the penalties are increasing. Could you tell us about that, please?
Sure. So for those of us that are older than I am, they may remember, you saw a patient, you billed for the patient, and that was the end of it. You basically billed for what you did. So it was basically a McDonald's model of healthcare, right? So you show up, oh, can I get one physical exam, please? And that was the end of it. So with that, the problem, especially in the US, became that the costs of healthcare became untenable, so became unsustainable. In the OECD countries, US became the one that spends the most and that gets the least in feedback. And this trend has been even more prevalent before the pandemic, the SARS-CoV-2 pandemic. And if you look at it, you can even see this with regards to, for the first time in a long while in US history, the life expectancy, particularly for a particular group, those middle-aged white men without a college degree, has actually went down. So that has been the push for CMS to sort of change the landscape on what was happening and how healthcare was being paid for. So ultimately, MACRA was passed. MACRA is the Medicare Access and CHIP Reauthorization Act of 2015. And it replaced the 1997 sustainable growth rate formula that ultimately determined the Medicare reimbursement. So if you remember, with the Medicare reimbursement, the Congress had to almost always every year come to the rescue because it was limited and the physicians weren't going to be paid enough the next year, so there were a lot of issues. So ultimately, the goal of MECRA was to provide a new approach in this reimbursement and somehow tie it to value and quality of care. With that, the alternative advanced payment model and merit-based incentive payment system. So two separate but related payment pathways were created. What we call MIPS is the merit-based incentive payment system. So basically, it has 6 goals: to improve patient outcomes, enhance clinician experience, increase advanced alternative payment models, promote understanding, improve data and information sharing, as well as ensuring operational experience. So if you think about it, these are all really big goals. And some of them have been achieved, some of them have not. But ultimately, it all boils down to triple aim, which has been another big driving force in the US healthcare from probably early 2000s, which is to improve the lives of people, meanwhile decreasing costs and improving the quality. But the cost is per capita. So basically what they're pushing down is that an ounce of prevention is worth a pound of cure. And that goes hand in hand with other approaches as well, because if you think about it, from our medical school years, we are basically taught to treat the disease, right? So if I see a patient with, I don't know, non-STEMI, I have a checkbox, metoprolol, check, ticagrelor, check. Or if I see a patient with diabetes, I have a checkbox. HbA1c uncontrolled under metformin, should I add another anti-diabetic? Should I add maybe insulin? Or it's just you're basically treating the disease, not the patient. And with all of these changes, the push is to ensure that, particularly from a chronic care perspective, we are treating the patient as a whole and preventing any complications. So coming back to the MIPS, what it did was it combined 3 legacy programs. For those of you, again, who remember, it combined the physician quality reporting system, the PQRS, the value-based payment modifier, the VM, as well as the Medicare EHR incentive program. Most of the practitioners that consult with you, that are listening here, will be eligible and maybe even in MIPS without even knowing about it. There's rare exemptions. I mean, if you're really low volume, meaning less than 90,000 a year of Part B or less than 200 patients, but you can still opt in. And from a penalty or from a carrot or stick, as I like to call it, perspective, we were looking at 1%, 2% in 2020, 5%. And then this year, we are looking up to 9% upwards and 9% downwards. And that is also with another 3 times the potential. So technically, although it will never happen, you can go up to 27%. And if we look at the projections of it, when MIPS was first coming into the picture, it was projected that the physicians that were practicing solo were going to be the losers, and then the bigger the clinicians, the bigger the group, they were going to be the bigger winners. There's a lot of reasons behind it, but ultimately, if you're a smaller fish in the pond, you're going to be having a hard time with hitting the quality and hitting the MIPS. There is different payment models, right? As I was stating with MIPS. MIPS is ultimately, to an extent, still fee for service. Correct. They ask you to do a lot of things, and then there's going to be upwards the carrot or stick with what you're billing. But the next level up is, as you stated, the value-based care or contracting. So basically, the value-based contract is ultimately what you are providing as a value-based care. So let's say there's multiple different ways of it. So let's start breaking it down from a single-sided perspective. So ultimately, under these alternative payment models, the providers are technically becoming financially responsible for the care they provide. It's almost as if that you are warranting the care you provide, right? So you take your vehicle to the shop, and let's say they change the plugs, right? And then next day you get an issue with the coil. So should they have noticed this? Should they have fixed it? Is it under their responsibility? So this is sort of bringing the same arrangement to healthcare. So upside risk or one-sided risk models, basically they allow the participants to share the savings if they make the care delivery more efficient. Meaning if you ensure that your diabetes population is doing better than the average population and they're not being hospitalized as much, etc., and you showed that you saved CMS $1 million, so you're going to be taking a share of it. So meaning they're incentivizing you to ensure these chronic diseases do not progress to be extremely costly. Because I can guarantee you that if a patient with type 1 diabetes goes into diabetic ketoacidosis, it's going to be $1 million bill versus a $10,000 bill for their insulin. And that enables CMS to ensure providers are meeting the necessary goals of quality by ensuring, does this patient not have a fridge at home, or was there power cut? So like, it's not just that you're looking at them from a healthcare perspective, it is also that you're ensuring they have access to appropriate social care, their social determinants of health are sorted out. And the payers are though more interested in the two-sided financial risk. So basically there's an upside and a downside. So basically, if we think about it, why would they want this? So basically, they also want the providers to warranty their work, right? They also want to penalize the providers. If the actual cost of care in that context exceeds what the average is, the benchmark, then the providers may have to pay some of the financial losses. So basically, if you look at it, if my patient population is doing really bad, then if I'm in a two-sided contract, the CMS or the other payer may ask me to chip in some. And there's different ways of doing it. One of the most popular ones is per member per capita, per member per month, or per capita per month, or per capita per year. So basically, you're getting a set amount of payment per disease or per patient, and that is for yours to keep. It doesn't matter how much the patients utilize the healthcare, you're ultimately bearing responsibility for it. So ultimately, from a value-based contracting perspective, you need to be in an advanced alternative payment model. Some of them are MSSP tracks 2 and 3. There's particular ones for primary care, end-stage renal disease, oncology care, as well as some for joint replacement. So there's also bundled payment models and stuff. There's a lot. But all you need to know is to ask the question to yourself, are you ready to take full responsibility for your patient population, to share both in their success and to share both in their success, I guess. It's almost as if what we are sort of doing with schools, in that schools that do not pass the benchmarks with the students that are failing grade level reading, math, etc., it boils down to the teachers, right? It may be the student's fault to an extent, but that's where the buck stops. So what CMS is trying to enable is that the buck stops with the physician, and the physician is the captain of the boat.